Finally, certainly not least, Professor Iodice, Professor of Autonomic Neurology at Queen Square. So she's travelled a vast distance to get to us, who's going to give us an idea about current research in the area, which of course will be vital, ongoing.
So good afternoon to everyone, and thank you, Nick, and thank you to POTS UK. So it's really a great pleasure to be here. So I will try my best to be brief. I know that it's a very long day, but actually it's been a fantastic opportunity. So we will discuss the autonomic dysfunction in long COVID and the overlap. I mean, you have heard quite a lot regarding the overlap with POTS and which are the current research. So touch on the autonomic dysfunction, then we have seen in patients in long COVID syndrome, our experience from a tertiary center with the pilot data and what we are planning for the future. So you have heard few times today then the most frequent autonomic presentation in post-COVID syndrome is a cardiovascular autonomic dysfunction. We are at the moment not really sure then actually that is the case. It's possible then actually this feature, the one then they are easily recognized in our clinic, and this is why is the most prominent referral to either secondary or tertiary care. So when it comes to cardiovascular autonomic dysfunction, you have seen in quite a few presentations, patients they may present with collapse, with lightheadedness, with dizziness, tongue pain, so if pain in neck and shoulder, then it does improve when the patient is lying down, exercise intolerance, or if fatigue then is triggered by other stimulus like post-meal, in particular with the large meal. So what is important to recognize, and this is where the confusion, I suppose, starts, and where we don't know the full story when it comes to COVID and long COVID syndrome, is then orthostatic intolerance is a label for very, very different disorders. So you have from one spectrum, something then extremely severe, so neurogenic OH, as Nick was mentioning this morning, which is a severe, is disabling, is persistent. So you wouldn't expect a patient to be well one day and unwell the second day, and it requires long-term treatment. So usually there is an underlying lesion of the autonomic nervous system in one of the pathway of either the central, the spinal cord, or the periphery. And then on the other side, you have a patient that then actually they might present to you with orthostatic intolerance, but in fact, that is not an autonomic condition. So it wouldn't surprise anyone if somebody after a prolonged bed rest might have orthostatic intolerance. If there is a very low fluid intake or maybe drugs, then they can cause the orthostatic intolerance, which not necessarily means an autonomic disorder. In the middle is the most, what we cluster as a benign, but actually the most difficult part of the orthostatic intolerance physiology, where you have a patient with a POTS and frequent reflex syncope. So so thinking about the orthostatic intolerance, why autonomic dysfunction might occur in long COVID syndrome? And I don't think, again, we have the final answer, but there are 3, 4 maybe scenarios. So either we are looking at an autoimmune inflammatory disorder, and this is why you will see the mention here regarding, I don't know if the pointer is working, regarding autoimmune pathology, so autonomic ganglionopathy. So one patient has been described by the case series in Mayo Clinic, and we have seen one patient with neurogenic orthostatic hypotension. The reason why ganglionopathy is mentioned here is because actually it does offer us a brilliant model to understand a little bit more regarding long COVID, because in this patient, we know exactly where the pathology is. So potentially a model then we can apply to study this patient. So it might be an autonomic neuropathy, and we will see a few examples later on, or as you have seen all this morning, inappropriate sinus tachycardia, postural tachycardia syndrome. So is it a transient problem of the autonomic nervous system, or actually in this patient we are observing a lesion of the autonomic nervous system? So there have been quite a few case reports. So this is the case series from Mayo Clinic that I was referring to. And you can see one patient had definitely an onset of an autoimmune autonomic ganglionopathy. This is a severe but treatable autonomic failure disorder. and the rest of the patient had fulfilled the criteria for postural tachycardia syndrome or mild orthostatic intolerance. However, even when it comes here to POTS and mild orthostatic intolerance, we need to do quite a lot to understand what we meant with that. So the reason why you have had today from brilliant talk from Nick and many other colleagues, what we would expect in a patient POTS, they do recover all the patient, they do respond all the patient to the same medication. What is the natural history of the disorder? The tricky part is then we are looking at a label to describe a very heterogeneous group of patients. So it's very possible that actually we're looking at several different disorders. So this is another study, more recent study, using a COMPASS 31, which is a very well validated questionnaire, which looks at 8 autonomic domains. And as you can see, this actually confirms that the patient, they do not have just cardiovascular autonomic dysfunction with orthostatic intolerance, but actually there is a widespread impairment of the autonomic nervous system involving the gut, bladder, and other pupillomotor, secretomotor domain, which it does resembling what we do see in our patient with POTS. So a lot of similarity. So maybe understanding long COVID, they will give us insight into what does happen in patients with idiopathic postural tachycardia. So this is our pilot study, which has been presented at the European Academy of Neurology this week, and we are grateful to the collaboration of many colleagues at UCLH. So we did look at our cohort of patients with long COVID syndrome, and this is just to give you a context. So in the whole range of patients we do see at our tertiary referral center, we see more or less more than 5,000 in outpatient per year. When we started auditing 6 months after the start of the pandemic, you can see that we were receiving more or less 5 new referral of long COVID syndrome per week. And now we are doubling the number, which obviously is a little bit concerning for overall for the health, the provision, the service model for this patient, but there might be then also people, they recognize long COVID syndrome much more than at the start, and this is why the referral. So I won't go into much of details. You have heard a lot regarding what post-COVID syndrome remain poorly understood, is substantially long-term patient health and economic implication. It seems to occur independently of the severity of the acute infection, as was pointed out just at the previous question. And the tricky part, then the study looking at autonomic function in this patient cohort, only few study patients that were assessed with the formal autonomic testing. So we did look at our cohort. So the cohort was of patients all referred with a suspect or a confirmed history of COVID-19. Majority of these patients, actually, they were referral from respiratory medicine at UCLH. You can see the mean number of days between the acute infection, the testing was 374, and ranging between 30 and 579 days. So 62 patients. Female 42, male 20, so ratio 2:1, the mean age of 41.3, an age range between 18 and 82. And this is again, it should raise some alarm of how heterogeneous actually is the patient cohort. So mild pre-COVID symptoms in 12 patients. In our cohort, obviously at Queen's Square, we have an interest in joint hypermobility. So every patient when it comes to the unit is also screened for that possible comorbidity. That was something very interesting to us. So we were looking at, is it possible that maybe there are predisposition factors? So this is a patient that, yes, has developed a COVID infection, a long COVID syndrome, but there is anything in the medical history that has unfortunately posed the patient a risk of developing a long COVID syndrome. So this is the range of symptoms, so not different to what you have seen this morning. So majority of the patient, palpitation is definitely very prominent, lightheadedness and dizziness, chest pain. So all the constellation of symptoms you would expect in a patient with orthostatic intolerance. So this is when it comes to the outcome from the autonomic, the formal autonomic testing. So what is very reassuring, Well, yes and no, actually. So majority of the patients, they present with intermittent disorder. So vasovagal syncope and postural tachycardia syndrome. We have seen a patient with neurogenic OH and a patient with initial orthostatic hypotension. The reason why I'm saying yes and no is because we need to understand a little bit more what is the underlying pathology of POTS. And I will show you one case. So when it comes to what we see in the lab, so these are all phenotype that you have seen this morning. This is what we would expect in a patient with POTS on tilt. And this is a patient with a vasovagal syncope. Of interest, I mean, this is a patient with initial orthostatic hypotension. So in the autonomic neurology, we would have assumed that actually this patient, they do have an intermittent disorder, so something benign, so a drop in blood pressure, then you can only capture if you are measuring the blood pressure continuously on a standing test. And you can see patient, it does generate an important chronotropic response with increase in heart rate and then a recover over time, yeah? So something that usually does reassure us, but actually was not the case in this patient cohort. So we did look at the patient with initial OH, and actually many patients with initial OH, they do have added dysfunction of the autonomic nervous system. So they do have a reduced heart rate variability breathing, which means parasympathetic involvement. So this is just to make the point that I guess we should not assume that we know the full story when it comes to autonomic dysfunction in long COVID. So the reason why I'm presenting this case is again to challenge a little bit the concept of what we meant with POTS. So this is a patient, 38 woman, developed dyspnea at rest, short of breath with minimal exertion, for example, walking upstairs at a home or speaking on the telephone. Fever, dizziness, chest pain, lightheadedness, and palpitation. So patient was tested, so same straightforward, postural tachycardia. This is a 24-hour blood pressure profile, then the patient does perform with a diary. They were the typical trigger, so postprandial exercise, then they did exacerbate the tachycardia, and the patient also presents with a post-exercise malaise and exacerbation of the postural tachycardia after a supine exercise. What it did concern us is that in the recovery phase, the patient was still presenting with this temperature and with prominent heat intolerance. So the question was, are we missing anything? So is it this patient actually does have a more broad impairment of the autonomic nervous system? So these are pseudomotor assessment of pseudomotor function. So this is the same patient who was evaluated with the post-ganglionic assessment of the nerve and the innervated sweat gland. So this is a normal control. Each of these dots is one sweat gland activated. So you can see that there is a significant difference in the patient, yeah? So that test is telling me that there is a post-ganglionic denervation. So this patient does have potentially a small fiber neuropathy. Now, if we were stopping here, it would have been a phenotype, then we can see in diabetes, in patient with other peripheral neuropathy, in patient with burning pain. So in the patient, then you would cluster as a small fiber neuropathy. However, this very profound heat intolerance is not justified by a length-dependent process. So a neuropathy, a denervation, that only does affect the distal part. So we did perform a thermoregulator sweat test, which you see here, if I can use it, yes. So this is a chamber where we can control humidity and temperature. We have a 16 channel where we can measure the skin temperature, and the graph you see here, the purple are the area where the patient is able to sweat from. The yellow are the area where the patient is not able to sweat from. We use a powder, then it does change color when the patient starts sweating. So you can see then the pattern is definitely not what we would expect in a small fiber neuropathy. It's very profound, a large area of anhidrosis. So this obviously, you know, require further study, and this is what we are planning now. But this is just to make the point. I don't think we know the full story when it comes to autonomic dysfunction in long COVID. It might be very benign in some patients, it might be moderate in other, or maybe even more severe at the end of the spectrum. And then it fits very well with the story that we know regarding postural tachycardia syndrome. So we call POTS something that is extremely heterogeneous. So some patients are neuropathic, some patients is because of their conditioning, other patients, they do have hypovolemia, splanchnic hyperemia, maybe some patients, they do have 2, 3 of this underlying pathology at the same time. And then we have the very strong association with joint hypermobility. So maybe one of the reasons why we cannot predict natural history, we cannot predict response to treatment, because we are looking at one label, but actually several different disorders. So in conclusion, in our pilot data, definitely majority of the patients, they had intermittent disorder. We did look at, we did follow up all these patients in clinic, and majority of the patients, they did improve. Again, this is very limited to small group pilot, so I don't think we can draw lots of conclusion. What we are planning for the future, and anyone that is interested, we would love and be delighted to collaborate, but we would apply a model that we know that it works extremely well. So I guess by now we are all familiar with the concept that actually this is a disorder that is multi-systemic. So when it comes to the autonomic, we can't use one outcome measure to capture abnormality. So we will use a model that we have used in the ganglionopathy, as you can see in this paper, looking at several outcome measures, and with the hope that we will be able to phenotype these patients. And by phenotyping this patient, we may be able to answer some of these questions. So this study will start in September. So as I said, we would welcome collaboration. Thank you so much for your attention.
So we do have time for some questions, which is.
So I was okay on time.
Oh my gosh, you were perfect. Look at that. I feel like the big bad time wolf. But so we do have any questions here before I flick back to my screen. People might be questioned out. That's the only thing. Otherwise, oh, we've got one at the back. Yeah, lovely. That's it.
Yeah, thank you. It's been brilliant meeting you. It was over a year ago, I think, on Teams, or maybe 2 years ago. But we've learned so much that we didn't even know we didn't know. One of the things that Patricia McNamara has been teaching us in the UCLH clinic is how to take a better autonomic history. And particularly this issue about the sweating is something that actually we've only really got to grips with in the last month. And one of our patients did have that abnormality that you described. So do you think there's a need for us to train post-COVID clinicians in this autonomic history taking? Because we've kind of got fixated on the palpitations and the postural symptoms, but there is actually more to it, isn't there?
Yes, Mel, I would say absolutely yes. I guess, and in the clinical history, there are many red flags that you can use from the clinical history to basically differentiate which kind of also phenotype we are looking at. Yeah, so definitely there is a plenty of scope. I mean, the clinical history in autonomic neurology, I would say, is the gold standard, the first step before any, autonomic testing. So absolutely yes. And the pseudomotor side, Mel, is very interesting because some patients, they will not perceive the anhidrosis. Yeah, it's very unusual for a patient, even with a large anhidrosis, so not lack of ability to sweat, to be able to recognize. Actually, patient, they will tell you the opposite. They will say, oh, I have developed hyperhidrosis of the chest. And then you test the patient. And in reality, the problem, obviously, then they are trying to compensate. Yeah, so the body. So the history, when it comes to pseudomotor domain, is very, very difficult because the perception of the patient is very difficult to capture.
Yeah. So we might need your help with these training resources that we're developing.
It would be a pleasure.
Thank you.